안녕하십니까, 주현철 원장입니다.
Greetings, I'm Dr. Juyeonchul. Today I want to talk about loading protocol of dental implants. These are the preconditions of osseointegration introduced by Brown and Mark in 1977. There are 8 preconditions. The third condition, which is a stress-free healing period of 3 to 6 months, is still considered very important. Depending on different situations, it's considered important, but for the patient, it can be very stressful to wait such a long period. Delayed loading requires 3 to 6 months of healing period, and for successful osseointegration, this is the most safe method. The downside of it is that the patient needs to wait for long healing periods and needs to wait a removable denture. Considering the fact that patient expectations are going up, we need to come up with better methods. When we're treating fully edentulous cases with fixed prosthesis compared with partial edentulous case, we need to come up with a better treatment plan. If you look at the timetable as shown, first implants were placed. Because of insufficient stability, they were submerged. Provisional denture was realigned using software liner. After that, 4 months was waited for sufficient osseointegration. Secondary surgery connecting healing abutments were performed. 2 weeks later, impression was taken and jaw relation records were taken. And within 5 months, temporary provisionals were provided. After the patient adjusted sufficiently to the provisional, final prosthesis was delivered, and it took about 8 months to do that. I believe that is a common hope for both the patients and dentists to be able to get similar results within much shorter time period. As shown, on the day of surgery, by loading a temporary provisional, you can reduce the loading period. This can be more favorable. After that, the surgeon and patient can be less stressed about getting final prosthesis and take more time. The reason why immediate loading and early loading became possible is advancement of material and technology. As implant design evolved from macro design to tapered form, we are now able to get primary stability better. Also, with the advancement of implants treatment surface, we can get secondary stability better as well. Thanks to biomechanical coupling, which combines mechanical aspect and biological aspect, implant design has been improved and immediate and early loading has now become possible. With the advancement of surgical technique, we are now able to get the primary stability better, and this is a factor contributing to immediate loading. There needs to be a criteria for immediate or early loading of implant, and the criteria that we can use is implant's primary stability. Implant stability is about how much the implant does not move clinically. It's about measuring that. This is not a criteria that directly shows osseointegration. It is an indirect criteria. Implant stability can be looked at in 2 different aspects. The first is primary stability that can be gained from cortical bone, and second is secondary stability that can be gained from cancellous bone. As mentioned earlier, implant stability can be divided into primary stability and secondary stability. Primary stability can be gained as the implant mechanically engages the cortical bone. As for secondary stability, this can be gained through bone remodeling after implant placement. By combining the 2 stability, you can get the total stability of the implant. We need to aim for secondary stability by using implants with good surface treatment. We need to get good fixation and primary stability to be able to do immediate or early loading. The easiest thing that we can adjust is primary stability. Primary stability is a crucial factor for successful implant treatment regardless of loading time. Clinicians need to improve their skills to get primary stability. What tools can we use to measure implant stability? Notably, we can use RFA values. You need to use smart peg accordingly to the implant that has been placed. You connect this smart peg and you get the resonance frequency. This figure is very difficult to read, and this is converted to ISQ value, which is much easier to read. The latest released Osstem beacon reads RFA. There is a smart peg and the instrument for Osstem beacon, and there's a smart peg mount which serves as a handle in connecting smart peg. There can be different smart pegs depending on the type of implants, so you need to choose the right smart peg for the implant. For regular platform TS implant as of 2021, type 61 is recommended. Prior to that, type 6 was recommended, and for short implants, type 47 was recommended, but now it has been unified to type 61, so please refer to it. If you go to Osstem homepage, there's different guidelines for different situations and figures and loading method. To summarize it into a table, if the ISQ value is over 70, and in the case of single implant case, immediate loading is possible. If the figure is between 65 and 69, immediate loading is possible in partial case. In the case of between 60 and 64, if it is fully splinted, immediate loading is possible. Also, in terms of early loading, the number goes down by about 5. For conventional loading, it is 5 less than that of early loading. These figures are what is reported in the literature, and this is not the formal value that is recommended by Osstem. So we need to remember that these figures are not absolute. As a result, when applying for the first time, rather than the numbers suggested by Osstem, we need to take a more conservative approach. My recommendation is that we need to increase by 5 from what is suggested by Osstem, and as we increase our clinical experience, we need to find the number that seems and feels right for us. Immediate loading is possible when it's over 75, 70, and as for full split cases, should be over 65. We need to reduce by 5 for different categories and find the right number accordingly with our experience. The ISQ values are supplemental, and it can differ by patient and by clinician, and this is something that we need to remember. This is criteria for immediate and early loading for fully edentulous case. In the case of lower, over 4 implants should be placed, and the insertion torque value should be over 35 Newton centimeters. Rigid splinting should be done. Provisionals should be provided so that occlusal force can be distributed easily. Because bone quality is softer in the upper, you need to place more than 6 implants. Also, cross-arch stabilization should be utilized. rigid splinting and occlusal distribution should be done. And in order to do this, provisional contour should be adjusted. These are key factors for immediate loading in not just fully edentulous cases, but for partial edentulous cases as well. When we do drilling, we need to get a tactile sense of bone quality, and following the patient's bone quality, we need to do adapted drilling. By doing this, you need to get appropriate primary stability. When fabricating provisional, the occlusal surface needs to be flat. At times, there should be shallow or no eccentric contacts. At times, we need to adjust antagonist to get ideal occlusion. At times, you need to adjust antagonist so you can get ideal occlusion. Rigid splinting and firm cementation are very important as well. However, despite all this, delayed loading is at times necessary. If significant ridge augmentation has been done, or when there is sinus floor elevation, parafunction, and other conditions, then delayed loading would be more favorable. Let's look at different cases. First is conventional loading case. On both sides of the upper sinus floor has come down significantly, so sinus elevation was done and delayed implant placement was done. Sinus elevation was done, extensive bone grafting was performed. Delayed implant placement was done. 4 months after sinus lift, using one guide in the upper posterior area, implants were to be placed. Implants were placed in the posterior area. The primary stability was about 5 to 15 newtons. It was quite weak, so implants were submerged. Soft materials were used to reline the existing provisional so that force would not be concentrated on the implants. 4 months after loading was done, delayed loading was done. Anterior implant placement was planned. Implants were placed. Provisional was delivered, and this is after final prosthesis delivery. In the case of extensive sinus lift, conventional loading should be done so that we can get more stable results. Next is delayed loading case. The patient had no posterior stop. Because of it, overall, there's flaring in teeth and there's also spacing observed. The patient hardly received any dental treatment, and the patient had a lot of fear of dental treatment and wanted treatment to progress gradually. The patient first wanted spacing in the anterior area to be addressed. In the upper and lower, root canal treatment was done. Utilizing the tooth that can be utilized, provisional was provided on the anterior area. The patient wanted gradual treatment, so starting from the upper posterior area where osseointegration occurs more slowly, one guide was used to place implants. After that, in the lower posterior area, implants were placed using one guide. 6 weeks following implant placement in the lower, ISQ values came out very high. All in all, the figures showed over 70, so provisional restorations were used for early loading. In number 15, natural tooth was extracted and immediate implant placement was done. In number 13, implant was placed as well. ISQ value was high, so early loading was performed. In the lower, number 32 and 42, bone grafting was performed along with implant placement. After osseointegration, provisionals were delivered, followed by final prosthesis. Except for the lower anterior, provisionals were fabricated within 6 weeks and early loading was done. The bone quality, if it is sufficiently hard, and if you can get good primary stability and choose good implants, you can do early loading. Next is immediate loading case. The residual tooth in the lower were not in good condition, so extractions were determined. Decision was made to do immediate loading in the upper and lower gradually. The bone quality of the upper was comparatively more unfavorable, so immediate loading was done here first. In the case of fully edentulous case, in order to use one guide system, you need to use a radiographic guide. A radiographic guide was utilized, and the plan was to perform one guide surgery. One guide template was fabricated and designed using Implant Studio. Template was printed out using 3D printer. CT check was used to check on the CT whether the implants were placed in the desired positions. After using CT check, you can see that implants have been placed in number 12, 14, 15, 17, and the upper right quadrant. In the upper left as well, it was confirmed using CT checker that the implants have been placed in the desired position using the template. Implants were placed in the upper, except for number 17 where primary stability was weak. Insertion torque value was all over 30 newtons. ISQ values were high, except for number 17 in the upper. Immediate loading was performed. Residual teeth in the lower were extracted, and in the same way as the upper, one guide surgery was prepared. In the same way, radiographic guide was utilized. One guide template was designed and it was printed out using 3D printer. The template was used to place implants in the lower. Insertion torque values and ISQ values were all high in the implants placed in the lower, and immediate loading was performed on all. This is provisional after immediate loading. After having the patient wear the provisional for a sufficient period, final prosthesis was delivered. This is intraoral image of final prosthesis. Let me summarize. You need to apply appropriate loading protocol for different situations. Especially for immediate loading and early loading, you need to have strict criteria established. Sufficient number of implants should be placed, and you need to make effort to achieve primary stability. What is most important is that you need to place the implant in appropriate position and direction. Through rigid splinting, immediate loading should be performed. If you're interested in more specifics, please refer to offline master course. I hope you come by and learn more knowledge. Thank you. Thank you for watching.